Good evening, everyone. It's really a pleasure to join you in this very special day for you, I know, and I really appreciate that despite all your activities, you were able to come and to listen to this webinar. So again, good evening, welcome everyone. My name is Hania Szajewska. I'm the chair of the Department of Pediatrics at the Medical University of Warsaw, Poland. My scientific heart also belongs to ESPEGAN, European Society for Pediatric Gastroenterology, Hepatology and Nutrition. And also my scientific heart belongs to International Scientific Association for Probiotics and Prebiotics. And today I will discuss with you approaches to prevent infections in toddlers or generally young infants. Okay, so let me start with this slide. And only 5 months ago, no one knew that something like SARS-CoV-2 or COVID existed. But now the virus has spread to almost every country, to your country, to my country. And it has changed the way we communicate, it has changed the way we live, it has changed the way we communicate scientifically. Webinars, it's something that only a few months ago hardly ever existed, hardly existed. I'm not saying not existed, but were not so popular. All of us are discussing COVID. All of us by now became very familiar with signs and symptoms of COVID-19, which includes fever, cough, shortness of breath, sore throat, fatigue, aches and pains, headache, runny or stuffy nose, and diarrhea. And of course, we know that there are some differences when it comes to adults and to children. Children have accounted for only 1 to 5% of diagnosed COVID cases. They do have milder disease than adults, and death is extremely rare. But when we look at signs and symptoms, as I showed you a moment ago, they are very similar to adults. My interest is in gastrointestinal diseases, so I'm also interested in gastrointestinal symptoms. And now we know that patients with COVID-19 also have GI symptoms, and they are very similar both in adults and in children. And we also know that virus RNA was detected in stool samples in as many as 50% of the cases. Does it matter? Yes, it does matter, because this shows us that there is a potential transmission risk via fecal-oral route. We also have infants who are born into a society affected by SARS-CoV-2 and COVID-19, and I like to call this generation Generation C from coronavirus. So in summary, we may say we have new problems crop up, but please remember, old problems remain. They did not stop existing. So what I would like to do now is to discuss approaches to prevent infections in toddlers. And what I will cover in my presentation, I will talk about common infections in early childhood, or especially in toddlers. How big is the problem? And then I will focus on interventions to reduce the risk of infections. And I will talk in this context, what is the role of gut microbiota and what is the role of micronutrients and vitamins, and especially of vitamin D. We'll focus very much on toddlers, as Mohammed said. This is a very special group of children. And what is so special about this toddlerhood, this is a period of motor skill development. Toddlers learn how to walk, to run, climb. This is a period of cognitive development. Please remember that a toddler's brain size reaches 80% of its adult volume. And finally, it's a period of maturing immune system and developing innate and adaptive immune responses. So this is, in a way, a very special period of childhood. Let's go back to the infections in early childhood, and let's try to see the answer. How big is the problem? And there are some data from various parts of the world, like this is quite recent paper from Australia. And this study shows that when it comes to acute respiratory tract infection, there are a common cause of morbidity in the first 2 years of life, and children can have 13 acute respiratory tract infections and almost 5 months of respiratory symptoms. These are data from Australia. There are some data, more recent data from Copenhagen, from Denmark, 14 infections during the first 3 years of life, and of course with substantial variation in frequency between individuals. But anyway, this is a common problem. And infections are also linked to the use of antibiotic treatment. And as many as antibiotics were administered to 25% of the infectious episodes, even if we know that the majority of those infections are in children are caused by viruses. And the use of, I should say, overuse of antibiotics is really a huge problem. And if you look at this very recent data published this year, there are data from US, but I'm sure it's very similar in many other countries. 25% of hospitalized kids get antibiotics they don't need. So overuse of antibiotics, it's really a huge problem. Infections, respiratory tract infections are the problem, but also the use or overuse of antibiotics with all its consequences. Not only is it a respiratory tract infection, also gastrointestinal infections. And let's say this presentation will be about 40 minutes, maybe a little bit more, a little bit less, but it's about 40 deaths, 40 children below 5 years of age are likely to die during this presentation. You may say, okay, this happens in very low income countries. It's true. But even in well-developed countries, in so-called well-developed world, it is a problem. For example, in Europe, every child below the age of 3 years might have 2 to 3 episodes per child per year. So gastrointestinal episodes of gastrointestinal infection. So my summary number 1 for this part of my presentation is infections and the use, or I should say overuse of antibiotics are significant problems in early childhood. And therefore, there has been a considerable intervention supporting the immune system and reducing the risk of infections. But I want to make it absolutely clear, there are no shortcuts. There is no specific food, no food supplement, no probiotic, no micronutrient, anything like that, that can prevent a person from catching infections, including SARS-CoV-2. Having said that, please remember that good immune defense, which depends on nutrition, which depends on virus micronutrient, is vital to combating infections, including SARS-CoV-2, which we are experiencing at the moment. And there is a range of factors, as I said, including nutrition, that have a role in supporting immunity. And that leads us to immunity. And this slide shows you something which you know very well, what are the components of the innate and adaptive immune system, because those are the systems which are so important. Innate immunity, which is non-specific, but very fast, within minutes of hours, and macrophages, mast cells, neutrophils, complement, all of them are playing a very special role in immunity. But also adaptive immunity, which is highly specific, but slow. And here we have this cellular immunity, but also humoral immunity. And we also are aware of all these different kind of CD4 helper subset, which may play a role in various situations, like Th1 response in various kinds of infections, Th2 in allergic disorders, regulatory T cells, which are important for immune tolerance and for induction of immune tolerance. We also know that there is a number of factors that can affect our immune system, many of them, including genetic factors, environment, microbiota, and nutrition. And in my presentation, in the next part of my presentation, I want to cover only some of them, and these are microbiota and nutrition. Let me start with gut microbiota. There is a lot of discussion about the gut microbiota and the role in immunity on this crosstalk of bacteria which are mainly in our gut and immune cells. We also know that early colonization is very important. Early, I mean during even neonatal period, so before the period which is of interest at the moment for this presentation. And we know how all these factors influencing neonatal colonization may either lead to symbiosis, immune tolerance, intestinal homeostasis, and healthy metabolism, or they may lead to dysbiosis with various diseases, chronic diseases, including allergy, obesity, etc. And at the moment, there's hardly any disease that is not being linked to dysbiosis. But we also know that there are age-related changes in the gut microbiota which occur not only during the neonatal period, but throughout our life. So age is important, feeding mode is important, family lifestyle, geographical location, genetics, the use of antibiotics, which I already mentioned, but also use of other drugs, including PPIs. All of them can further shape the microbiota, also during this toddlerhood, which is the period of interest at the moment. And there is one additional issue, which is maybe very important. This is the use of disinfectants. It's highly recommended for nowadays because, among other factors, because of the persistence of coronaviruses on surfaces, on plastic for 5 days, on glass 4 days, on wood 4 days. So this persistence and the use of disinfectants is important, but there might be some consequences. Impact of microbiota. In fighting against SARS-CoV-2, we might be losing several other microbes that defend us. So this is something that we have to consider nowadays. And as a matter of fact, if you look at the literature, this was published before the COVID-19 pandemic. But anyhow, there are some consequences of household disinfectants, for example, on infant gut microbiota and subsequent risk of overweight in children. So this is something that has to be studied. But anyway, to summarize it, it's clear that the gut microbiota plays an important role. And if the gut microbiota plays such an important role in immunity, then there's interest in gut microbiota modifier. And on this slide, I summarize all these modifiers, but I will not discuss all of them. I will discuss just one, and these are probiotics. Let me start first, and because it's important to discuss whatever is possible in the context of the SARS-CoV and COVID-19. This is a very recent document. I would not even say it's a guidance from International Scientific Association for Probiotics and Prebiotics. And I had the privilege to be part of the board of the directors of the ISAP, and very recently we published this guidance, and we concluded that no probiotics and prebiotics have been shown to prevent or treat COVID or to inhibit the growth of SARS-CoV-2. This is important keeping in mind, but there is a very recent paper, and some of the co-authors of the ISAP board of directors, some of the members of the board of the director of ISAP co-authored it only 3 days ago published. And the title speaks for itself: using probiotics to flatten the curve of coronavirus disease COVID-2019 pandemic. And they are saying that 13 probiotic strains help to prevent bacterial and viral infections, including gastroenteritis, sepsis, and respiratory tract infections. We'll discuss some of the data in a moment. And they also concluded that at a time when doctors are using drugs with little anti-COVID-19 data, probiotic strains documented for antiviral and respiratory activities, not low quality, undocumented in limitations, but really high quality products, should become part of the armamentarium to reduce the burden and severity of this pandemic. So it's a very clear message. There is no any probiotic which has been proven really to act against SARS-CoV-2, but still for other viruses, yes. And now I would like to talk a little bit about the evidence about the probiotics for preventing and treating respiratory tract infections. Let me start with probiotics for preventing acute upper respiratory tract infection, and this with this Cochrane review. And as you can see, I am just showing you something that may be applicable to pediatric population. There were 5 randomized control trials carried out in children with almost 1,500 participants, and the use of probiotics as a group, generally speaking, reduce the risk of upper respiratory tract infection by approximately half, 57%. There is another systematic review and meta-analysis published quite recently, which looked at probiotics not only for prevention but also for treatment of respiratory tract infections in children. And here you see that there was an 11% reduction for experiencing 1 or more respiratory tract infection. 11% reduction. They also look at the data on the absence from days absent from daycare or school. And as you can see, the pool results show almost 1 day reduction, mean difference 23 hours. And this data from the absence from daycare or school are important, especially in the context of the discussions that we have today. And I would like to focus in more detail on that. Because as you know, those children who are attending daycare are up to 3 times higher. The risk of common infections up to 3 times higher compared to children cared for at home or in family care groups. And this is one of the recent systematic review and meta-analysis which looked at probiotics for preventing respiratory tract infections in children attending daycare centers. 16 randomized control trials. They look at the risk of upper respiratory tract infections and probiotics as a group can reduce the risk of upper respiratory tract infection. Again, probiotics as a group can reduce the duration of symptoms if used during the disease. And last but not least, they can also reduce the risk of antibiotics. And I already told you, there is a tendency to overuse antibiotics in many settings with all the consequences of this overuse. So my summary number 2 is that probiotics as a group, I discuss all of them taken together, that probiotics as a group may reduce the risk of or the duration of respiratory tract infections. But we know that not all probiotics are the same. And therefore, in the next part of my presentation, I want to focus on one of the probiotics, which is very close to my heart because we have done a lot of studies with those probiotics. And it's also one of the best studied probiotics. And the name of it is Lactobacillus rhamnosus, ATCC 53103. You may know that all these numbers, all these letters are very important because they show you what is the culture deposition. So it's like an ID, like a passport of these microorganisms. There's also another name, Lactobacillus rhamnosus GG or LGG. And marketing, please remember the marketing and trade names might be different because manufacturers can call the probiotic products if they want. So for example, they might be just the name Lactobacillus rhamnosus or just LGG or whatever. But what is important for us as clinicians, for us as scientists, that we always need to know what exactly is behind these marketing or trade names. So today, if I will be speaking of Lactobacillus rhamnosus, even without mentioning all these numbers and letters or without mentioning LGG, please remember that I am always discussing this particular strain, Lactobacillus rhamnosus ATCC 53103, or which is equivalent to Lactobacillus GG. And in the context, in the discussions that we have today, there are 3 studies, important studies on Lactobacillus rhamnosus for preventing common infections in children. I want to focus on one of those because I had the privilege to contribute. Eva Hojsak from Croatia is the first author. It was a randomized, double-blind, placebo-controlled trial, which was carried out in 4 daycare centers. And for 3 winter months. This is in Europe, when most of the viral common respiratory tract infections occur. So those children were randomly assigned to receive Lactobacillus GG or placebo, almost 300 participants. And as you can see on this slide, with the use of the probiotics, there was reduction in the gastrointestinal infections, although the difference was not statistically significant. There was reduction in the respiratory tract infection, relative risk 0.67, 63 means we reduce this risk by 37%, almost 40%. And there was also reduction in respiratory tract infections lasting longer than 3 days. It was reduction by 43%. So more or less reduction altogether by 40%. And this translates into so-called number needed to treat, which is 5. So 5 children would need to be treated for 3 months with this with Lactobacillus GG in order to prevent 1 child of having respiratory tract infections or respiratory tract infections lasting more than 3 days. So my summary number 3 for this part of my presentation is that the use of Lactobacillus rhamnosus GG is an option to be considered for reducing the risk of common infections in children attending daycare centers. And the majority of those children are toddlers. So that's why I'm discussing it in the context of the discussions that we have today. I would also like to cover another subject, which is the prevention of nosocomial diarrhea. As you know, this is one of the major problems, and it's usually caused by rotavirus, and it's especially common in young children, particularly in children younger than 2 years. And the risk is much higher than if you look overall 8 incidences per 100 hospitalization. And this is a systematic review, the meta-analysis that we published already some time ago, that you look at Lactobacillus rhamnosus GG supplementation for prevention of healthcare-associated diarrhea in children. And as you can see on this slide, there was reduction in the risk of diarrhea, there was reduction in the risk of rotavirus diarrhea, rotavirus gastroenteritis, even if there was no difference in asymptomatic rotavirus infection. One of those studies is a study which was carried out by our team, and it was published already some time ago in the Journal of Pediatrics. And as you can see, the use of Lactobacillus GG reduced the risk of nosocomial diarrhea by almost 80%. Very big reduction in the risk of nosocomial diarrhea, one in children. One of these major problems that we have in hospitals. With number needed to treat, again, 5. So 5 children would need to be treated with Lactobacillus GG in order to have 1 additional child free of nosocomial diarrhea. So my summary number 4 for this part of my presentation is that the use of Lactobacillus rhamnosus GG may be considered in hospitalized children to reduce the risk of healthcare-associated diarrhea. What is new in 2020? So let me talk about 3 documents. 2 of them are from ESPEGAN Working Group on Probiotics, and one is from the team which was working on the new names for Lactobacillus species. And let me start with these 2 documents from ESPEGAN Working Group on Probiotics. I have a privilege to be part of this group. And this is a very recent paper which will document clinical guidelines on the use of probiotics for management of acute gastroenteritis. And I'm showing you because the probiotics that we discussed today, Lactobacillus rhamnosus, is one of the probiotics which is recommended. It's a conditional recommendation, but it's recommended for the management of acute gastroenteritis. And it's already available on the JPJN website. So if you're interested in more details, you can read it in the document. In the May issue of JPGN, Journal of Pediatric Gastroenterology and Nutrition, there is also another document which was developed by the ESPGHAN Working Group on Probiotics, but also by the Committee on Nutrition of ESPGHAN. It's on prevention of necrotizing enterocolitis in preterm infant. Even if we are discussing toddlers today, I decided that I will show you this document because I think it's important to show that the probiotics which we are discussing is not only effective in one group of children, but also in other groups. And Lactobacillus rhamnosus is one of those which is recommended for preventing necrotizing enterocolitis if all safety conditions are met. So I briefly showed you what are the two new documents from ESPGHAN, and I also would like to show you a very new document published only in April. And this is important, and this will change the way the way we name some of the Lactobacillus species, because new names have been given for important Lactobacillus species, including Lactobacillus rhamnosus or Lactobacillus GG. And the new name is Lacticasei-Bacillus rhamnosus. People are saying it will take us approximately 2 to 3 years before we will learn all these new terms, but we have to learn them because this is just happening. And so the new name is Lacticasei-Bacillus rhamnosus. This is a full document if you want to read all the details, but you can also go to a very short summary which was published by ISAP, International Scientific Association for Probiotics and Prebiotics, and you can see the one-page infographic with a summary. And Lactobacillus rhamnosus, as you can see here, the new name is Lacticasei-Bacillus rhamnosus. But I have some good news for you because the abbreviated form remains unchanged. So we can use L. rhamnosus. It will be not Lactobacillus, it will be Lacticasei-Bacillus rhamnosus, but the short name, the abbreviated form remains unchanged. So my summary number 5 for this part of my presentation is new recommendations support the use of Lactobacillus rhamnosus for the management of acute diarrhea. And this is in context of the discussions that we have today, but also in the prevention of necrotizing enterocolitis, which is just for your knowledge. And of course, it does not relates to toddlers. And Lacticasei-Bacillus rhamnosus is a new name of Lactobacillus rhamnosus. Please remember the abbreviated form remains unchanged. Okay, so I'm done with this part. And now let me quote Oscar Wilde. I can't stand people that do not take food seriously. And the reason I'm quoting Oscar Wilde is because now I want to move from probiotics to nutrition. And I think we can all agree with what he said, because nutrition is important. Nutrition in immune response against viral infections. There are 2 important recent papers published very recently on this particular topic. I will not go into detail. I will just try to summarize in the context of vitamins and micronutrients. And both vitamins and micronutrients have key roles at every stage of the immune response. And this is summarized here at the physical barriers, innate immune response, adoptive immune responses that we discussed previously. And inadequate intake and status may result in reduced resistance to infection and increased disease burden. Zinc, very briefly. Zinc plays a role at every stage of the immune response. We have to remember that even if severe zinc deficiency is rare, mild to moderate zinc deficiency may be common worldwide and then may affect immunity. Iron, look, almost every stage it is involved. And deficiency of iron is associated with fewer T cells and less cell-mediated immunity. Selenium, again, in almost every stage, process is involved and plays a role in cell-mediated immunity, has an anti-inflammatory effect, remove reactive oxygen species. And last but not least, there is some role for vitamins and especially for vitamin D. What is the rationale? And I would like to cover a little bit in more detail vitamin D. What is the rationale for vitamin D and using vitamin E in the context of the discussions that we have? So there is a number of observational studies which shows associations between low serum concentration of 25 hydroxy vitamin D, the major circulating vitamin metabolite, and susceptibility to acute respiratory tract infection. And there are also in vitro data showing that 25-OH-D vitamin D supports induction of antimicrobial peptides in response to both viral and bacterial stimuli. So we do have some rationale for using it. But of course, what we need are clinical data. And we are in a lucky position because we have this systematic review and meta-analysis of individual participants' data. Look, almost 11,000 participants in 25 randomized control trials, children and adults, and look at the results. When they pull the results of all meta-analysis of all studies, it shows a 12% reduction for experiencing one or more acute respiratory infection, irrespective of dosing schedule. Or odds ratio 0.88 means a 12% reduction. But of course, we are interested here in children. So therefore, I highlighted yellow these studies in children, and I decided I will look in more details for you. Unfortunately, you have to trust me, but anyway, there were 8 randomized control trials, more than 6,000, almost 6,400 participants, relative risk 0.84, which means there is reduction by 16% in the risk of at least one acute respiratory tract infection. Children, it was children with some, it's not exactly toddlers, children with various, but anyway, it applies to children. There is also a lot of discussion about the dose, and there was a study published almost 3 years ago in JAMA, and they looked at high dose, which was 2,000 units versus standard dose, which was 400 units, and vitamin D dosing higher than 400 units per day may not be indicated, so both doses were equally effective. Vitamin D is something which is in the focus of interest of ESPGHAN Committee on Nutrition, and this is consensus statement published already a few years ago. And the ESPGHAN called our attention to the fact that vitamin deficiency occurs commonly among healthy European infants and children not adhering to the present recommendations for vitamin D supplementation. And unfortunately, it is in my part of the world, it may happen despite all the recommendations for vitamin D supplementation. And there are also studies, the FEED study, the Feeding Infants and Toddlers study carried out in the United States. And it also showed that vitamin D was one of 4 nutrients that toddlers might be short on. So the deficiency, vitamin deficiency may be a problem, and we have to be aware of it. There is another ESPGHAN Committee on Nutrition position paper that I would like to call your attention in the context of the discussions that we have, and this is on young child formula. And while the routine use of the young child formula, so those for children above the age of 1 year, is not recommended, it's clearly stated that it may be used as part of a strategy to increase the intake of iron, vitamin D, and that's why I'm showing it to you, and also polyunsaturated fatty acids. So my summary number 6 for this part of my presentation is vitamin D supplementation can reduce the risk of respiratory tract infections in both children and adults. Many infants and children are at risk of vitamin D deficiency if they do not receive proper supplementation, and young infant formula may be used as part of a strategy to increase the intake among others, of vitamin D. So I did cover this nutrition part, and now I know that the audience is likely to remember only 3 things from each presentation or speech. So even if I provided you with a number of summaries, I just want to summarize in a shorter summary, so only just 3 take-home messages. And my 3 take-home messages are as follows. Infections. Infections are responsible for significant burden during the early childhood, and toddlers are at risk. We discussed that gut microbiota plays a role in immunity, and I showed you that there are strategies for gut microbiota modification, and I discussed in more detail probiotics and especially Lactobacillus rhamnosus GG. And finally, nothing that children eat will stop them getting infected. However, inadequate intakes impairs immunity and may have long-term consequences, and I discuss it in the context of vitamin D. And let me finish with a final quote, and my final quote is, and I just will make the comment that I usually show it to our medical students, our residents, and I hope that you will appreciate it also. And this is, half of what you are taught as medical students within 10 years have been shown to be wrong. And the trouble is, none of your teachers know which half. It very much applies to my presentation, and it may happen that if we will meet in real life, hopefully it will happen one day, some parts of my presentation will need update. Thank you very much for your attention.
Thank you, Professor Hania, so much. It's very comprehensive, very engaging, very new as well. Recent publications. So thank you so much. It's really, we didn't want the presentation to end, but I think it's time to get some questions. We have plenty of questions here. So if you open the Q&A tab with me, we can go scrolling through the questions.
I can see it. Okay, so I will go from the top. That's some nice words. It's always nice to read all these nice things. Now I go down. Okay, good. No, good evening, good evening, good evening, good evening, good evening. It was probably at the beginning. I go down.
There are some questions related to the respiratory infections or the COVID. One of them, if the mother is diagnosed with COVID-19, should she continue breastfeeding?
Wait a minute, I need to find it. Good evening. But it's also a pleasure to see how many people are.
No, I think we need to open the Q&A tab rather than the chat. If you open the chat, so we can open the Q&A one.
Okay, everything is clear. 40 days infant, egg breastfeeding with severe eczema all over the body, after which diet elimination of the mother was done for 4 days. What is next? After which diet elimination for the mother was done for 14 days with no improvement. Well, one comment on eczema, atopic eczema, especially, but anyway, eczema. One of the, in about 15, 20, 25% of children, this is caused by cow's milk allergy, but there may be other causes. So I think if the child was, or the mother was on the whatever was on the elimination diet, and there is no, and it was full elimination diet, and there was no effect, I think what is needed is just to check whether or not the diagnosis was, whether it's due to cow's milk allergy. Perhaps it's something else. Thanks for the updates of SARS-CoV-2. I would like to know if the mother to diagnose suspected shall continue. Yes. And there are some, I mean, I think that first of all, until now, the SARS-CoV-2 has not been detected in breast milk, and all the organizations, WHO, Centers for Diseases Controls, European guidelines, they do recommend continuation of breastfeeding. There might be the situation that mother is too sick to breast herself, and then it might be that you may think about banking or something like that. But generally, this is not a contraindication. You mentioned SARS-CoV-2 and COVID-19. Is there any difference? Yes, there is a SARS-CoV-2 is a virus that causes COVID-19. COVID-19 is a disease caused by the virus, SARS-CoV-2. And so there is a difference. Is there a relationship between BCG vaccine and the incidence of COVID-19? My understanding is that current stage is that there is no relationship, even if this has been discussed. Before a couple of days, they announced that Turkey had producing a drug for managing cases. I am not aware of any drugs that has been now proven to be effective in COVID-19. I know that there is, I think, when I was checking it, it's more than 1,000 clinical trials, among them really a lot of randomized control trial, not so many in children, but so far, as of 11th of May, none of the drugs has been proven to be effective. We are of course also waiting for vaccination, but it will take some time. There was and still is a rush of buying vitamin C and Hania products. Can the product raise child immunity? There was some discussion on vitamin C. Echinacea, no, that should not be used. Is there any correlation between probiotics and COVID-19? I did hope that it was quite clear that the ISAP position, as ISAP stands for International Scientific Association for Probiotics and Prebiotics, position from May, 1st of May, that there is no probiotics with proven activity which, for preventing or treating, preventing SARS-CoV-2 or treating COVID-19. So it's very important, even if...
I think it's too early as well to say probiotics work or not. It's a bit...
Sorry?
It's
at
too
the
early
moment,
to say.
there is no, we don't know what I'm saying. At the moment, there is no, but the reason behind it is that we don't have any studies, and you're absolutely right. In order to say, yes, one of them is effective or not, we have to do the studies. But I also showed you this paper published only 2 or 3 years ago from leading people from ISAP, saying that there are other probiotics with documented efficacy in viral diseases, not in COVID, but in other viral, which shows that it probably some research should go also in this direction. I would say, especially in prevention. I'm not so sure about the treatment, but for the prevention. But of course, we need, like for everything, we need randomized control trials. So, and I'm always saying as of today, because tomorrow we might have different data, and especially in the context of SARS-CoV-2 and COVID,
Exactly.
it's very important.
It changes every moment.
It changes. I mean, you know, I mean, today it may be true, tomorrow it will be not true. Okay, there was still a rush of buying. Okay, there's correlation I already discussed. How the PPI affects the microbiota? Very good question. And it is like with antibiotics, they do have a tremendous, and there's overuse in infants, in toddlers, of both, and PPI as well. Both have an effect on microbiota. There was a number of studies showing association between the use of antibiotics, but also PPI, proton pump inhibitors, and increased risk of allergic disorders and obesity. You can read in JAMA or JAMA Pediatrics, I think two years ago. Can we use probiotics in the first days of life? Yes, we can use it, but only use probiotics with documented efficacy, not any probiotic, because it's really important to use that. So like, for example, infant formula supplemented with probiotics are considered safe. I also show you the data on the use of probiotics for preventing necrotizing enterocolitis, so even in preterm infant. But what is important, always to use a probiotic with documented efficacy. Incidence and prevalence of infectious disease in toddlers, rational use of antibiotics. Incidence, I already commented on these respiratory tract infections, up to 15 during the episode, during the first 2-3 years of life. When it comes to gastrointestinal infections, at least in Europe, it's up to 2-3 episodes per child. in children below 3 years of age. For the rational use of antibiotics, very limited. And as a matter of fact, there are 2 indications for use of antibiotic for gastrointestinal infections. This is Shigella or Campylobacter early in the course. For respiratory tract infections, if you have bacterial infection, then otherwise most 90% are viral. So for example, again, in the context of the discussions that we have, probiotics, and also Mohammed, what you are saying in the context of SARS, most of the diseases viral are caused by viruses. That's why my colleague from ISAP are saying, well, it's something that has to be studied. We have to see whether it's not, perhaps it's also effective when it comes to prevention of SARS-CoV-2. We will see. I'm sure there will be studies. What are the probiotics that should be present in our children's gut and quantity? Well, I think it's important to talk which indication we are discussing, and then to say which probiotic to use, because there are various probiotics, but I think the probiotic with bacterial probiotics is best documented efficacy in many diseases is Lactobacillus rhamnosus GG, but there are also other Lactobacillus reuteri for prevention of infantile colic. So it really depends on the indication. And when it comes to the doses, it always depends on which indication we are talking. What makes the risk of getting infected higher in children attending daycare? Well, because you have all these children with various diseases. Nowadays, I don't know how it is in your country, but in my country, children are staying at home because there's lockdown. So kindergartens are closed, daycare centers are closed, schools are closed, etc. And children are not sick because they are staying at home. They are not communicating with one another. Once they will start to communicate, we will have exactly the same. So they are just exchanging various infections. Is there any interaction between these probiotics at what should be present in gut? Well, probiotics, I just want to make sure, we are talking about gut microbiota, all the microorganisms which are present, not only bacteria, but also viruses, fungi, etc., which are present in our gut. Probiotics are live microorganisms which are added, which are given, which are administered usually orally. So at what age, should be present, but at what should be, I would say, should be given. And then it depends on the indication. If you want to prevent necrotizing enterocolitis, you give it very early. If you give it for treatment of acute gastroenteritis, it's another. So it really depends on the indication. Community-acquired resistant bacteria is highly emerging nowadays. Would probiotic have a role in replacing those harmful and minimize the colonization of resistant bacteria? I think that it's better. First of all, it's true that resistant bacteria is highly emerging nowadays, but still viruses are number one when it comes to respiratory tract infection. And even if there are some studies also for with regard to bacteria, I think what is best documented is for viral diseases. We are still confused, not feeling safe in providing breastfeeding in mothers in confirmed positive COVID-19. So what is the evidence to providing probiotics with formula? I think these are 2 different questions. Why is breastfeeding and COVID-19 in mothers, and most of the, perhaps Chinese recommendations were more strict. They really wanted isolation of mothers, but WHO really recommends breastfeeding. In our Polish guidelines, we do recommend breastfeeding. In European guidelines, it's the same. As for disease control, so I don't think any problems. And again, until now, the presence of SARS-CoV-2 has not been documented in breast milk. So this is not a contraindication. And what is the evidence in providing probiotics with formula in full term to reduce the risk of coronavirus? For reducing the risk of coronavirus, no evidence. I repeat again, we don't have, perhaps it reduces, we don't know. We need data to show you. So we can only make conclusions based on what is available at the moment. Role of plasma-rich antibodies in the treatment of COVID. No randomized control trials, a lot like a promising intervention, but I think we need, like for any intervention that we are using at the moment, randomized control trials. And I think most of the organizations, group of experts are saying, yes, you can use it in the context of clinical trial. What would you say for them is the main difference between the use of antibiotics and probiotics health-wise? And which one has a bigger impact, positive and negative? Well, it depends, of course, on the indication. For meningitis, for sepsis, it's absolutely clear that I would use antibiotics, no doubt. For bacterial pneumonia, definitely antibiotics. But probiotics in many conditions, I think, I don't know how it is in your country, but for example, in my country, for diarrhea, nowadays antibiotics are not used so commonly, but they used to be quite commonly, even for diarrhea, because parents are expecting you give them something. So I always say it's much better to give probiotics with documented efficacy, that we do not have something. So it's not the choice than antibiotics. And the parents will feel much better that they receive the child receives something. It's not the discussion what is better, antibiotics and probiotics. You have to outweigh the benefits and risks. And moreover, please remember, if you are giving antibiotics, the risk of giving antibiotics, one of the risks is antibiotic-associated diarrhea. So you may need to use probiotics to reduce the risk of antibiotic-associated diarrhea. And for example, lactobacillus GG is one of the probiotics to reduce the risk of antibiotic-associated diarrhea. For how long we can use probiotics? Again, it depends on the indication. Whether you wanted to prevent respiratory tract infections. I showed you the study by Eva Hoysak, and in this study, the duration was for 3 months. If you use it for prevention of infantile colic or treatment of infantile colic, the duration will be different. For treatment of acute gastroenteritis, it's usually 5 to 7 days. So it really depends on the indication. Does probiotics have harm effect with taking the higher dosage in cases of infection? Well, there is no need to use higher than doses that it was used in clinical trials which showed the effect. However, I'm not aware, and I have not seen in the literature, that they are the reports of overdosing of probiotics. From which age you can use probiotic? Again, I already discussed it, that it was used even in preterm infants for preventing necrotizing enterocolitis. They are being added to infant formula and used for many, many years. So, I mean, there is no lower limit. It's important what is indication. Do you have advice? Probiotics for every antibiotic use is indicated. The ESPGHAN recommendations are clearly stating, if you use an antibiotic which with a risk of which provides a risk of antibiotic-associated diarrhea, then you should consider. And if this means, for example, in pediatrics, amoxicillin with clavulanate, those are commonly used antibiotics, and there is a high risk. Yes, in such situation, in hospitalized children, probably in the children who already had antibiotic-associated diarrhea in previously, it makes sense. Are they debate over the use of in preterm infants? I already showed in my presentation, there is a recent position paper from ESPGHAN, and there were lactobacillus GG and the combination of 3 strains. These are the 2 interventions that are recommended for prevention of necrotizing enterocolitis. The paper you can download for free from the website of the Journal of Pediatric Gastroenterology and Nutrition. What about the dose, duration, and frequency of using prebiotics? Already commented, it depends on the indication, and then might be very short or maybe very long, it depends. Dose of probiotic in prematures, please go to the ESPGHAN position paper. You will see all the details, also which probiotic should not be used. How much the concentration for Nido Plus for each feed, that I cannot answer, maybe Mohammed will answer.
But it's the same dose that that was studied. It's, I think, 1 times 10 to the power of 9.
I don't know what is in the formula.
No, it's 1 times 10 to the power of 9. It's
okay.
Yeah.
Dose of Lactobacillus GG in preterm infants. Again, go to the paper, you will find all the details. Either a debate over the use of preterm, I already commented it. Probiotics play a crucial role in preventing respiratory infection. Is there any treatment protocol including probiotics in treatment of COVID? As far as I know, there are already registered protocol in adults. I'm not aware of the protocol in children. So, I mean, we have to wait for the results. I know that this already commented, there's more than 1,000 registered randomized control trials. So we will probably hear in the near future a lot of data. Is there any difference using Lactobacillus GG versus Lactobacillus reuteri? Well, it depends which indication you are discussing. Lactobacillus GG, Lactobacillus reuteri, for example, has a very well documented efficacy for preventing and treating infantile colic. Lactobacillus GG has a very well documented in other indications, like, for example, treatment of acute gastroenteritis, prevention of antibiotic-associated diarrhea, prevention of respiratory tract infections. So it depends on the indication. Does a probiotic cause immune flare-up in patients with autoimmune disease? Theoretically speaking, it can, but I'm not aware of any data or any report, any clinical report. But theoretically speaking, yes. In preterm infants, when should we start the probiotic to prevent necrotizing enterocolitis? Very good question, and it's not very easy answer, but when you start enteral feeding, you probably should start, but the data are not very conclusive. So whatever we have written in our recommendation is really like a conditional recommendation. So rotavirus vaccine is not enough to prevent diarrhea unless we give probiotics. Rotavirus vaccine is very effective and it reduces very much severe cases of rotavirus and reduces the risk of hospitalization. Still, some children, even despite being vaccinated, may do have diarrhea, and then the use of probiotics will be, with documented efficacy, will be rational. But by the way, we do not have many studies in the population vaccinated against rotavirus. These studies are also needed, but nowadays everyone is busy with SARS-CoV-2 and COVID-19. So I don't know, people will be doing other studies. We are almost forgetting about other diseases, which is not good, because they do not go away. How long we can use a dose of probiotics? There is no one single dose that will fit everyone. So it depends on the indication and probiotic. How long would you keep your patient on LGG supplementation to be effective in preventing antibiotic-associated diarrhea? In our guidelines, we clearly stated it should be started as soon as antibiotic therapy is started and given during the whole antibiotic therapy. Some people are saying plus 7 to 10 days. There's no agreement, definitely for the whole duration of antibiotic treatment. How long I have to use probiotics to give the toddler immunity against COVID-19? Allow me to repeat again, at this stage, we do not have any data to say that any of the probiotics reduces the risk of infection with SARS-CoV-2 or COVID-19. People are studying it. However, having said that, I will repeat, we do have studies showing that some of the probiotics reduce the risk of other viral diseases, whether or not SARS-CoV-2 and COVID-19 will be among them, we will see. LGG reducing necrotizing enterocolitis by which %? Well, I have to look into it. I don't remember what was the relative risk. Probably about, I just don't remember. You have to check it in our paper. I just don't remember. It's safe for Lactobacillus rhamnosus to be used prevent NEC, and which safety measures should be taken? Like for any probiotics, we would like to have a probiotic with which is from reliable manufacturer. So we must be sure that this is a strain which is on the label, in the amount which is on the label. So the quality has to be proven. And of course, as there are no for any probiotic, for example, antibiotic, there is no risk of the transfer of antibiotic resistance gene. In most, for LGGs, this is not a problem, but generally speaking, this is something that has to be considered. Again, please look at the paper. We discuss it in the safety issue in details. In this is the effect of probiotics.
I think we need to go a bit quick with the questions.
I am doing my best.
Some repeated
Mohammed.
ones, we can skip the repeated ones.
Okay. What is the safe level? Is there any side effects of overusage of probiotic? I think I already, is there effects of dose dependent? No, it's not dose dependent. It's not well documented. Perhaps some studies are suggesting in antibiotic associated diarrhea, but not well documented. So always use a dose which has been proven in well conducted studies. If the child doesn't eat well, no, for improving appetite, I'm not aware. Contraindication for probiotics use in toddlers. Probiotics are generally considered to be safe, and there are no contraindications for otherwise healthy toddlers.
I think the question would count for strain specificity rather than probiotics in general.
Say again?
I think the question, probiotics in general, wouldn't be very relevant at this point. I think if we talk about the strain specificity or something, then we can.
I always say about the strain specificity. Yeah. Always, it's always, and I'm repeating again and again, depends on the indication. Look what is the indication, and use probiotics with documented efficacy. Because as I said also in my presentation, not all probiotics are equal. So we always have to look which probiotics we are discussing. Contraindications for probiotics use in toddlers. Probiotics are generally considered to be safe. However, if there's a child, an immunocompromised child, with central venous catheter, then you have outweighed benefits and risk. Iron is important for immunity, but can be given during bacterial infection. Wait until it recovers. Is the same to be said by using LGG for cancer patients who develop due to chemotherapy. Very difficult question, not well documented. A lot of discussion whether you have to outweigh benefits and risk. During illness, it's appropriate to include probiotics as a beginning or as a convalescent period. For gastrointestinal infection, we recommend to use early at the beginning, and also during the respiratory tract infection, it was given together with whatever treatment was given. So generally, it's like at the same time. Does it include pneumonia or... when the speaker uses the term respiratory, I was trying when it was clearly stated in the, for example, in meta-analysis, upper gastrointestinal infections, I was saying upper gastrointestinal. It was just respiratory tract infection. I was saying respiratory, but it's a good question. But most of the infections in children are upper respiratory tract infection, not the lower. What about the effect on vitamin D on gastroenteritis? No studies. That, and this is not the indication. What is the cutoff vitamin below which are the most frequent? I don't think that we can say it based, but I can tell you that the dose, I don't know if I understand the question correctly, but the dose which is recommended is usually 400 in small 400 units, but I'm not sure this is what you asked. Can we consider lactobacillus rhamnosus as a treatment for diarrhea? Treatment is, first of all, rehydration and proper nutrition. And in addition, one can use probiotics with documented efficacy. Mohammed, documented efficacy. And one of them is lactobacillus rhamnosus.
Yeah. Specific.
Exactly. Any studies on Clostridium difficile infection? Yes, they are, but it's not well documented indication for Clostridium difficile infection. Saccharomyces boulardii in our pediatric guidelines was the one which was recommended. Thanks for the nice comment. Deficiency and bone fracture in children. There was a lot of discussion, but I think there is a study, meta-analysis even, and it's not long-term, there is not well documented. Thank you very much. Is there any age limit for probiotic use? You mean upper or lower? No, generally no age limit. Can I give probiotic in bacterial infection? We are giving antibiotics. Yes, if you are giving antibiotics to prevent antibiotic-associated diarrhea, yes. Mohammed, there are so many questions. I'm not sure I will answer all of them.
No, let's take let's skip the repeated ones. Maybe.
Okay, I will just check how many antibiotic associated, how long you should keep substance was how long to give toddler immunity against COVID-19. I already discussed it.
I can probably skim through the ones and
I will
just
look at the end.
No, I can. What's the role of prebiotic in treatment alone in children? Would you consider it?
Prebiotics. Now I have to see the question. Wait a minute, because if I don't see the question, it's very difficult. What about duration of probiotic therapy for viral gastroenteritis? 5 to 7 days. What about probiotics in yogurt? Everything depends which probiotic and what is the efficacy behind it. So there's no one general answer. It just always look at the evidence. Can we give probiotics after any course of antibiotics? After does not make sense, there is no evidence, but during the antibiotic therapy, yes. I have 3 case Kawasaki disease in a relation between it and coronavirus. I have to check in the literature, but I'm not aware of it. But you know, the disease, we didn't know anything about it 5 months ago. We are all learning every day it's changing. Can we use in toddler with asthma as it can improve immunity? I'm not saying you cannot use it, but as far as I know, there is no data to support like a routine use. Is probiotic indicated in breastfed baby as breast milk contains probiotic? I mean, for example, Lactobacillus reuteri is very well documented efficacy for treating infantile colic, especially in breastfed infants. So this is one of the situations that you will use probiotics. Can probiotics be given in immune deficiency? Immunodeficiency is one of those conditions that you have to outweigh benefits and risk and to see whether you can use, but generally for many probiotics, by many manufacturers, it's considered as a contraindication. What is the mechanism of Vitamin D in preventing disease? I showed you what are the observational data to support it, and I also show you some of these in vitro studies, so it was in my presentation. Is it wise to consider children having deficiency of depending only on serum in spite of having, I mean, the serum level, I mean, we don't, you don't have it, but it is a good indicator whether, what is a, whether or not, what is the status. So I would say I would use it. Effect on lactobacillus in respiratory system mucosa and what main mechanisms of prevention. I did not discuss in detail what are the mechanisms of action of probiotics, and there is no one single mechanism of action, but definitely through all these immunological effects for viral cytokine. So then you have systemic effect and